First topic of the day is going to be HIT, H-I-T, heparin-induced thrombocytopenia. So the hallmarks of this is decreased platelets, right? So that's where your thrombocytopenia portion comes in. Heparin-induced, so they could have gotten subcutaneous heparin or low molecular weight heparin, Lovenox, or it even could be incited from a heparin-infused line. And it's typically then on the second exposure where we get a tremendous decrease in platelets, and we say like 50%. So say someone comes in and they have 150,000 platelet count, and all of a sudden you see their platelets at 75,000. It's like something's wrong, something's going on here. Could this be heparin-induced thrombocytopenia? So it's actually an autoimmune type process. So we have anti-platelet factor 4 that we test for. And then the true confirmatory test is an SRA, or serotonin release assay. But this right here is extremely important to think about whenever you have a patient, especially in the ICU setting, whose platelet count drops greater than 50%. So heparin's mechanism of action is it increases like anti-thrombin levels by multiple thousands of magnitudes. And so the way that we typically treat HIT is with what we call an argatroban drip. And argatroban is a direct thrombin inhibitor. And thrombin, prothrombin is factor 2A, to thrombin is factor 2. And then factor 1A is profibrinogen to fibrin. And again, this is just where our clotting cascade is going to end. But that's the treatment because you're actually in a prothrombotic state if you develop HIT, heparin-induced thrombocytopenia.